My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation educational series webinar. This evening, we're going to be looking at clinical data, patient photos, and dosing and administration of an oral treatment option for adults with moderate to severe plaque psoriasis. Our moderator this evening is Dr. James Del Rosso, who is Research Director, Principal Investigator at JDR Dermatology Research in Las Vegas, Nevada, Adjunct Clinical Professor of Dermatology at Touro University, Nevada, Henderson, Nevada, and President of the American Acne and Rosacea Society. Our speaker this evening is Dr. Benjamin Lokshin, who is Director of the Clinical Trial Center, Derms Associates. We'd like to thank our supporter, Bristol Myers Squibb, for making this educational event possible. Before we begin, if you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. If you could fill it in and send it to us, we'd truly appreciate it. Within 1 to 2 days of the webinar, a certificate of attendance will be sent to you. Again, if you'd like to ask any question to our faculty, please submit your questions in the question chat pane on the right-hand side of the screen. And I wrote a note there so you can see exactly where you have to write your questions. So without further ado, I'll pass the floor virtually to Dr. Del Rosso.
Thank you, Roxanne. It's certainly a pleasure to have the opportunity to participate in this program tonight. As was mentioned, I'm Jim Del Rosso. I'm a dermatologist in Las Vegas, Nevada. I am the stunt double for Dr. Leon Kursick, who normally moderates these programs but is not available. So I'm always very, very happy to do it. So obviously, Dr. Leon Kursick is the one that is really behind the International Dermatology Education Foundation. This is a nonprofit organization that has had a very respectable mission, and that's to raise awareness and improve the care of dermatology, not only in the United States, but around the world, with some focus on underserved areas. So there have been several previous educational sessions from several different sources, a variety in terms of the presentations. And to stay up to date with the IDEF educational series webinars, there are different sources here. You can see at IDEF_derm. You can see on LinkedIn at /IDEF derm, and on Facebook at IDEF derm. And visit the website www.idefeducationalseries.com to register for upcoming events. There are a variety of events, and I'm sure you're going to find them to be very, very helpful to you. So it's a pleasure to introduce someone that I've been getting partnered a lot lately on a lot of different initiatives, and it's been an absolute pleasure. He's a great guy, very knowledgeable, and a lot of fun. That's Dr. Benjamin Lokshin, who directs Clinical Trial Center at Derm Associates. He's in the Washington, D.C. area, and he has a lot of clinical experience. I'm going to be talking about clinical data, patient photos, dosing and administration of an oral treatment option for adults with moderate to severe plaque psoriasis, which, Ben, I'm sure you heard about that disease state, didn't you?
Once or twice. I have to say my clinic has pretty much been narrowed down to eczema, psoriasis, vitiligo, alopecia areata. My wife is disappointed that I don't do any cosmetics, and really anytime I have a question regarding my kids and their dermatologic conditions, I'm fairly useless to her. To all of them.
Get used to it. Your wife will be disappointed in other things too as you move along in life. But let's get going with the program, Ben, and thanks for being here.
Sure thing. And we're gonna start with a little video just to get this rolling, which is actually the intro to this deck. If it wants to play.
Yeah, just click in the middle. Yeah, there you go.
There we go. And Roxanne, I think we're having some technical difficulties in terms of the sound coming through.
We are.
So I would say move past it, Ben.
Yep. Okay, well.
Nothing you can do. Thank you, Emily.
Emily did a wonderful job articulating how her psoriasis affected her life to a meaningful degree, and so TIC2 had changed her life. Okay, moving on, if I can get out of this.
You can.
Roxanne, can
I'm
you?
just going to take the video. I'm just going to do this for you.
Emily's not giving up.
Yeah, Emily wants her payday. She wants her
No, I think, Emily, that's the kind of fortitude you have to have when you're fighting psoriasis. Can't give up.
Yep, she's
Exactly.
talking about how much her life has changed with TIC2. Okay, Roxanne, where are we at here?
There we go. And hold on, we'll just do this.
Oh, there we go. And she's a speed reader and a speed talker.
I'm just going to do this.
Perfect.
Okay.
And there you go.
Okay,
All right.
here we go. So as Jim had mentioned, I'm Ben Laksh, and I run our clinical trials center and psoriasis treatment center. I co-managed the a rheum derm clinic for a number of years and was on the board of directors for the National Psoriasis Foundation. I've had the privilege of doing the clinical trials and obviously working with TIC2 in clinical practice, as well as many of the other drugs out on the market. And I do think it's a privilege for us to manage patients with psoriasis in this era, as we have so many different options to get our patients better, from either orals to injectables to infusion medications, and mixing them and matching them to the way we see fit to get our patients clear. Whoops. This basically says that no one's getting CME for this program. Everything that I'm going to present is consistent with FDA guidelines. I do have some disclosures, as you can see below. As one of my mentors told me, I can't be bought by any company, but I can be rented by the hour. I'm being rented by, BMS promoting TIC2, but this should be a very fair and balanced conversation. And Jim will be my color commentator as well, interjecting periodically to add some color and insight and wisdom. Really what we're going to highlight is the fact that this is once daily dosed oral medication, first in class, that is a TIC2 inhibitor. And the newer data, that is the 5-year safety and efficacy data. And spoiler alert, no new signals, no amplification of safety signals. We'll get to that a little bit later. So how do you determine when a topical is no longer enough for a patient with moderate severe plaque psoriasis? And are they systemic ready? Well, the question I always ask my patients is, do you want to be proactive or do you want to be reactive dealing with your condition? And systemic medications in my eyes are proactive, which they treat the psoriasis before it appears. They keep patients clear. They do a good job, rather than topical therapies for the most part are reactive, which is when you have a spot, you treat it. And I think when patients have areas that are of special interest, including the scalp, face, genitals, palms, and soles, these automatically upstage patients in my mind and put them into a moderate category, and certainly an earlier consideration to migrate into a systemic therapy. But really, when patients aren't doing well on topicals, or are burdened by topicals, or potentially experiencing side effects attributed to topicals, or perhaps are on track to have adverse events related to the topical medications, we really should think about other options for these patients. And
So
this,
and
yeah.
how much does body surface area go into your determination of going to systemic therapy? Obviously, special sites that may be limited involvement, you're still going to upgrade that patient in your mind. But how do you use a body surface area cutoff that had been forced on us for many years, or how are you handling that?
It's a great question. In clinical practice, I don't use a formal cutoff, but I will say there's a couple different ways to get you to moderate disease. It could be the National Psoriasis Foundation guidelines, which defines moderate as 3 to 10% body surface area. Greater than 10% is severe. It could be in their global assessment of moderate, which is a 3 out of a 5-point scale, from 0 being clear, 1 being almost clear, which are the endpoints in the clinical trial: 2 moderate, 2 mild, 3 moderate, and 4 severe. And then the last one is a PASI score of 16 or greater, which is really never used in clinical practice. So my feeling is if they meet moderate by any of those criteria, either a PGA or a BSA or tough to treat areas, I think that they're, systemic ready. What are your thoughts regarding this?
I feel the same way, but I do agree with you that special sites, move people up, and also, what's going on with the patient, what they've gone through. They've been around the block with several different topicals. They're psychosocially, and that's not only a buzz phrase, that's a reality with these patients. They're at that tipping point where they want to move on. They want to get better. They've been going on with this for a while. So I think the more of that we capture, I agree with you. And systemic therapy treats other components of the disease, what's going on in terms of circulating cytokines. It's not just the disease that's limited to the skin. So I'm in full agreement with you.
It's a great point. And I always tell patients, this is psoriatic disease, not psoriasis vulgaris or psoriatic arthritis or, any of the other comorbidities that are associated with it. And it's a systemic inflammatory condition that just happens to have one of its manifestations on the skin. Very sensitive buttons. We're going to talk about a couple of cases. This is Zach. Okay. Zach's topical treatments are no longer enough for him, and he's ready for systemic treatment. Okay. He's got moderate plaque psoriasis, predominantly affecting his arms and backs. His plaques rub against his clothes when exercising. They can itch. They can also be painful at times, with individuals. He's got a family history of depression. He's been on multiple topical medications, and doesn't want more of the same. And we hear this time and time again. Patients get burnt out. They're looking for something that's different. And sometimes they'll see other providers that stick to really the very formal criteria for meeting, systemic agents. They have to have 10% BSA, and they have to have 3%, PGA of 3 and a PASI of 16. And yes, that is the formal criteria for entry in clinical trials, just like this trial. But like I said, there are multiple different ways to get to moderate. So when topicals aren't enough, really think about starting Sotyktu. And that's going to be the theme across this, which is when you're thinking about making that transition from a topical to a systemic agent, this should certainly be a very meaningful consideration for that first systemic agent that you go to, because of the ease and the oral options. And we're going to talk about the data, especially compared to apremilast, in terms of the convenience with daily dosing, and more importantly, improved efficacy. And just talking about efficacy, we're going to talk about that 5-year efficacy in a few minutes. How do you determine whether Sotyktu is an appropriate choice for patients like Zach? Well, the reality is, in my clinic, I don't go through every single option with patients. My job is to help curate, a few meaningful, reasonable options for these patients, and help with a joint decision making, make the right decision for that patient. So I don't give them all 15 options and prove to them that I know all the different therapeutic options. I say this would be a really good option given the location of psoriasis and the distribution. Jim, how do you manage?
It's same thing. You're looking at the patient. They're there. Yes, you want joint decision making, but they're coming to you because of some expertise you have to help them with that joint decision making. So looking at your situation, here are a couple of options that I think would really fit best with you, and then boil it down to those, and then go from there. I agree with you, right?
Thanks.
It's not our job to show them how smart we are on every single option, right?
Yeah, as my father said, just because you have a watch doesn't mean you need to tell everyone the time. More importantly, they are seeking out our opinion. As I tell patients, I'm here to educate you so you can make an informed decision for yourself.
Right.
And this is almost as confusing as the New York subway system. This is the pivotal phase 3 studies, which is poetic psoriasis 1 and 2, as well as the long-term extensions. Primary endpoint was 16 weeks. The eligibility criteria is consistent with all systemic agents: greater than 10% body surface area, PGA of 3 or 4, a PASI score of 12 or greater, And the endpoints are co-primary endpoints of a PASI 75 and a PGA of clear or almost clear, with a number of secondary endpoints as well. Patients, even though the primary endpoint was 16 weeks, at 24 weeks, based on their PASI score, they were re-randomized either to Sotyktu or apremilast in each of the groups at 52. That was the end in that of Poetic 1 and 2, and that goes into the long-term extension going out.
I mean, it does look like a New York City subway map, but there's a rhyme or reason to all of those. You're seeing a comparison with apremilast, then you're seeing what happens in patients that didn't respond adequately to apremilast to see if the Sotyktu makes a difference efficacy-wise and even side effect-wise. And then it allows us to look at a large number of patients that received Sotyktu over a prolonged period of time. So it looks like they just threw this at the wall, but it was really very well thought out, I have to say.
Yeah, I agree. And also a robust study with over 1,600 patients. You make an excellent point there.
I'll try to make excellent points, Ben.
So how did this medication perform? And let's just highlight Sotyktu at first. We see the Poetic 1 up top and Poetic 2 down below. Week 16 is the primary endpoint. And we see over 50% of the patients achieve a PGA of 0 or 1. In terms of PASI 75, between 53 and 58% of those patients achieve that in both the medications, dramatically higher than the gray bars represented by placebo. This is analyzed by the non-responder imputation, which is the most strict way of looking at the data. Now, the dark gray bar in this slide actually represents apremilast. Okay, so street name Otezla. And what do we see? Quickly, the lines start to divide. And by week 16, the primary endpoint, close to twice as many patients achieved a PASI 90, which is a certainly much higher bar for entry or in terms of clearance. And then we see at too excited. At week 24, we see further divide, increased efficacy with both the medications, but the 6% greater with Sotyktu compared to apremilast. Remember that Sotyktu is dosed daily, apremilast is dosed BID.
And they did blind it, so they had to put an outside covering so you couldn't tell which. The patients didn't know, and nobody knew whether they were getting the Sotyktu or the apremilast. They call it double dummy, right? So they were blinded, even though the apremilast was twice a day. Right?
Yep. So both the investigator and the patients were blinded. And this actually brings up a good point. During this pivotal phase, we're really trying to achieve three things with this study. One, show clinical superiority. Two, is look at safety in a blinded manner between the two medications. And three, to validate the data that we see with Sotyktu. So if the data with apremilast is similar to their pivotal phase 3 studies, which it was, that further validates the data that we see with Sotyktu. Okay, and setting the bar even higher over here, we see on the right in terms of PASI 100 scores, we see, in Poetic 1, 14% of the patients achieve complete clearance at week 16. We see 18% at 24 weeks achieving complete clearance. And this is a really good real life patient at baseline and 24 weeks after starting the medication. This is that shock and awe. I think we've all seen what psoriasis looks like in clear skin, and we're able to achieve this with a once daily oral medication. And I know we talked about, this should be considered the first line agent for patients with moderate disease, but certainly these images are showing more severe disease. And we see that response rates in the clinical trials were pretty much the same throughout the spectrum of disease. So it doesn't just work for low moderate patients, it works across the entire spectrum of BSA and PASI scores. Any comments you want to add to those images, Jim?
I think it just gives you an idea of what you're able to achieve with an oral agent. There's no therapy that we have, regardless of which of the therapies to psoriasis, that are going to work universally on everyone. So, that's something to consider. And the oral agent that easy for them to take, doesn't have the box warnings of other Janus kinase inhibitors, and you'll get into why that is. It's relatively easy to use, no drug interactions that they need to be concerned about. So it's a very straightforward medication that's really turned out to be overall very safe and very effective. I think that's well said, man. So you're doing very good so far, Dr. Lockton.
I think you make me extremely nervous. I mean, your man personality and knowledge base. But let's take the data out even further. So this is the 5-year data, and what we see is horizontal lines. And I think this actually is one of the highlights of a small molecule like Sotyktu. Larger biologic agents, IgG monoclonal antibodies, which the lion's share of all the biologics we use are monoclonal IgG antibodies, short of etanercept, which is a fusion protein. But without getting into the weeds too much, those are very large proteins. And I think that there is decreased efficacy over time at variable rates with all of these biologic agents. And we really don't see that with small molecules. And remember, small molecules operate inside the cell, biologics work outside the cell. So what we see here is a chronic condition like psoriasis being managed with the medication that works along the entire 5-year spectrum without any meaningful loss of efficacy. And this is also looked at in a very stringent way with the modified NRI, which is really the strictest way of looking at long-term data. And really just the only people that are not counted in the interpretation are the ones that have a good reason for dropout that were not related to loss of efficacy of the medication. All other patients were deemed as treatment failures if they didn't have a good excuse for discontinuation. So the top bar represents PASI 75, and we see out to 5 years, 2/3 of those patients achieve a PASI 75. We see a PASI 90, which is, remember, 90% reduction in that PASI score, which is much greater than 90% improvement of their skin. That's really close to perfection, about 50% at week 52, and in the exact same number at 256 weeks. I would not know that it's 5 years. Thank God it says 5 years below. Let's just talk about Maya. That's Maya. She's 26. She's a grad student. Okay. She got scalp involvement. Okay. And for a long time, I didn't think scalp involvement was such a big deal. I was like, okay, don't wear black. It's hidden by your hair. It's not a big deal. But the more and more that I treat patients with psoriasis, the more I learn that the itching, the unpredictability, the plaques that actually move right to the edge of the hairline, the alopecia that can be associated with thick psoriatic plaques are devastating to these patients. And many of the individuals say the same thing. When giving a talk or leading a meeting, I'm more concerned about what people are seeing and thinking on my shoulders than what's coming out of my mouth. So the impact of disease for scalp involvement, I think, is disproportionately large compared to other areas. Do you have any thoughts on this, Jim?
No, I agree with you. I could think of a few patients that came in that were very much like Maya. Maybe a little older. They were women that were busy. They were involved in business. They were coming in with their navy blue business suit. And why are you here? They weren't undressed, asked to undress yet by the staff. And then they part their hair. I don't see anything. They part their hair and they have these thick plaques of psoriasis. That how am I going to get medicines in there? Applying. It's not that easy to get even some of the best topicals we have when they have a full head of hair. And just what you described is what they were experiencing. And I walked in the room and I didn't see why they were there. And what they were there was right in front of me, but they had to show it to me. And then some of them do have it extending, or if they pull their hair up, if they put their hair back, you can see it right along the edge or behind the ears. It bothers these people immensely. It's easy for us to, I don't want to say dismiss it. I don't think you were, not caring. It's just we have so many other things on our mind that we're thinking about that maybe we don't give it its full attention. But it's their full attention. So I agree with you. I become much softer, kinder, and gentler because of the work that we're doing with these patients in clinical studies, finding out more about what bothers them day to day.
Yeah, and we really get to know those patients in the studies and hear a lot more detail than what we would do in our 10-minute interaction in the clinic once a year or twice a year. It should be noted that, generally scalp psoriasis is one of the first locations that presents. The average age of onset for psoriasis is age 27. Occipital scalp is statistically the highest, greatest location where it does present. So she's has a penicillin allergy, also on an oral contraceptive pill. And I think it's important to note this, not because she's on an OCP, but she's already taking a pill. And if you ask patients in my area, and I practice in the Washington, D.C. area, if they're taking medications, I don't care if they're 12 or if they're 80, they're on something. All my high school kids seem to be on stimulants. All the 30-some to 40-somes are on statins or blood pressures or stimulants. So adding a pill once a day doesn't seem to change the routine. And, adding to that, almost everyone, it seems, is on some sort of a vitamin as well. So, I always look at the medication list. If they're already on something, adding one more thing to that pill box doesn't change it at all.
And some of my patients here in Vegas tell me the things that they're on, but they don't want me to write it on the medical record, right? They're taking something. They're taking something.
Well, hopefully, a lot of that's legal now.
Yep.
So I think we already covered this. What factors and goals do you prioritize when treating their moderate plaque psoriasis? And one is quality of life, and two is the application. We have a limited formulary of things that actually work in the scalp, and most patients don't like any of the options. And I think this actually kind of rolls right into the efficacy. We looked at the patients in the Poetic 1 study, and what we saw is 70% of those patients actually achieved a scalp-specific PGF clear or almost clear, and that was about twice the rate that we saw with apremilast.
And that is a specific assessment geared to the scalp, because a lot of studies don't include the scalp in their global assessments. That was tailored to looking at the scalp specifically, correct, Ben?
Yep.
That scalp.
And this is a really good illustration of thick psoriatic plaques. At baseline, by week 16, we see dramatic improvement. I wish actually he didn't let his hair grow out so we could even see it better, but we see by week 24, there's nothing there. I mean, this is a changed man.
Yep.
Another image, thick psoriatic plaques. I mean, you can just imagine, if it were me, I'd certainly let my hair grow out. I really appreciate the fact that he shaved his head, for easy scoring. But you see the retroauricular area here, and as the plaques are migrating to that, occipital neck hairline, no matter what amount of hair you have, it still kind of pops through. And then let's just talk about that dural response. This is the theme of the day. We see, once again, really by week 16, you kind of hit that steady state. 74% at week 16 which was the primary analysis, out to 52, and then out to 5 years, the same numbers. This is Jill. She's 56. She's a baker. Yes, she's got moderate plaque psoriasis on her lower extremities, forearms, hands. Visible plaques, and this is really kind of highlighting hand involvement, which I think is very critical. And I love the choice of pictures, and I don't want to blow it, but we'll get to it in a second, of the case that they showed for palmar psoriasis. But I don't know about you guys. The patients that I have hate using topicals on their hands. It gets all over the place. It ruins things, especially the ointments. These newer generation creams are a little bit better, but your hands are greasy. No one likes putting on topicals. So for palmar and plantar disease, I almost always, right out the gates, recommend a systemic therapy. Okay. Yeah, her treatment's not meeting her expectations. She doesn't want her psoriasis to be on her mind when interacting with customers. It's embarrassing. It also, what she does, the flour that she's working with, you can almost imagine just drying out her hands, the fissures that it's creating. And I'm sure if a customer looked at her hands while she was working, probably would walk away and go to the next vendor. And when do you consider a systemic therapy for plaques on the palms and soles? Well, we already talked about that. For me, it's right out the gates. And if looking at this slide, if you go, oh, they forgot the placebo, gray bar, they didn't. It was just 0%. And the palmar-plantar PGA of 0 or 1 in this group of clear, almost clear palms and soles was achieved in 56% of the patients at week 16. This is a dramatic change in their life. Okay. We're going to show a picture, and then I'm going to let Jim chime in for a second.
No, I was just showing that when they went longer, they improved even further. They got up to 67%, 50. So the longer they went, beyond the 16 weeks, they continued to improve even more.
Yep, and a post hoc analysis of the patients did continue to get better.
Right.
And I think that's actually important to note. And this also is with, at what point do you cut bait? At what point do you give, a little bit of hand holding to say stick with it? And my feeling is if they're having a reasonable response rate at 12 weeks or 16 weeks in your clinical practice, knowing that the curve is going to continue to rise, especially for palmar-plantar disease, it's worth saying, hey, let's add a topical potentially if you need it for a flare, but let's give it a few more months, because I don't like cycling through medications, but at the same time, you want to make sure that you get off a losing horse. I always say you never get off a winning horse, but you also want to jump ship and not go down with the ship. So this patient, I really love the choice of images they included, because as we saw early in the deck, we had a lot of patients with pretty severe disease. And you end up saying, oh, well, I'll reserve any systemic agent for really significant disease. This doesn't look like a lot until you get close, and you can just imagine how this is impacting their quality of life, okay, in terms of pain, discomfort. But from a distance, if you didn't have this, you're saying that's not a big deal. You can march on. But to these patients, this is a huge deal. And we see by week 24 in a real patient photo, virtual clearance. And by week 52, we see, it looks like complete clearance of that hand. Jim, do you have any thoughts and comments on this slide?
I think that what involves the hand and some other locations, you don't always have to have that visible, horrendous looking case that a patient like this is still getting fissures, still getting areas that their hands, this patient's hands are going to be extremely sensitive in many cases, even though you're not seeing that thick hyperkeratosis or that characteristic thick plaque psoriasis. The hands are an area that there's a lot of mobility, a lot of natural lines that fissure, and it's very symptomatic, can be very symptomatic. So symptoms are important to capture here, sometimes more than what it looks like.
Absolutely. And I'm sure you have in your clinic patients that come in with just 1 or 2 fissures on their hands for one reason or another, either hand eczema or psoriasis, and it's driving them bonkers.
Yep.
Anytime they wash their hands or use instant hand sanitizer, it burns, it's disruptive, it interferes with their work. So don't downplay the significance of any extent of palmar-plantar disease.
Right.
So we talked about efficacy. We talked about efficacy in the scalp. We talked about it with palmar-plantar disease. We talked about it with just psoriatic disease in general, psoriasis vulgaris. Let's pivot for a second, talk about safety. And not only do we highlight the 5 years of efficacy data, we're going to highlight the 5 years of safety data, which in my eyes is just as important. So what are the most bothersome, and that choice of words is interesting, adverse events for your patients with moderate to severe plaque psoriasis? Well, for me, some things that are bothersome are things that I have to articulate to the patients that may or may not be of true relevance. But for patients, bothersome side effects kind of fit into 2 different groups for me. One is the intangible bothersome, which is the rare and scary, which the likelihood of them experiencing is extremely low, but the fear factor is high, like a signal for cancer or death. And these are things we do not see with this medication. And the other is the common things that in terms of convenience, headache, diarrhea, nausea, any other things that they may encounter day to day, which with this medication, we really don't see a lot. And we're going to actually dive into that in a second. So looking at this, let's start with the right, and this is kind of how, we'll start Hebrew style. We'll start from the right, then move to the left. What we see, discontinuation rates at 16 weeks were over twice as high with apremilast rather than Sotyktu, and placebo was stuck in the middle. So the discontinuation rates due to adverse events was the lowest in that Sotyktu group. And actually, if you get down to the number, the nitty gritty for that patient, we see 2.4% of those patients. Now let's talk about adverse events that are greater than or equal to 1% of patients and more frequent than placebo. And we see, a slightly higher rate of CPK levels in patients on Sotyktu versus placebo. Now I will say, this is a moving target. It moves around a lot, and there's no recommendation for checking CK levels. I do not check them unless it's clinically appropriate in the right patient that has complaints, but I do not get baselines. And like I said, certainly if patients are working out the day before, it's going to affect that. Do you order CPK levels?
No, I don't. Not as a routine. And what's interesting, even before Janus kinase inhibitors of any type came to dermatology, they were used a lot in rheumatology and other areas. And there was a big consensus group of individuals that used a lot of Janus kinase inhibitors. And even they stated, we don't see the need to do routine testing of CPK levels, even before they got to dermatology. And these are patients with a lot of comorbidities beyond what we typically see. So that's very, very interesting. Right?
I think that's an excellent point. So numerically, we also see slightly higher rates of folliculitis, mouth ulcers, acne, and upper respiratory tract infections. To be honest, in clinical practice, I have not seen these complaints to any appreciable amount. Herpes simplex, I will say just across the board, I always ask that in the history for patients. My threshold for suppressive treatment is extremely low for treating any patients, and that's on systemic agents or not on systemic agents.
I mean, to put a patient on valacyclovir, which is, I don't want to say as safe as water, but almost, and very effective, there's no reason to have a high threshold to do that. It's very, very easy to do and not going to harm anybody and very inexpensive. So
yeah, and I always tell patients when I recommend it, I said, this is actually one of the few medications that we know that has disease modifying effects. If you stay on it for a long time, the number of outbreaks in a few years is lower than had you not been on the medication.
Right. We even are able to give it to women who are pregnant at any point in time in their pregnancy. It's considered that safe, not even worried about the fetus. It's incredible.
No, it's an excellent point. So out to 52 weeks, what do we see? Well, in terms of adverse events leading to discontinuation, the Sotyktu group continues to be the lowest compared to apremilast and placebo. Serious adverse events are comparable to what we see with placebo. Numerically, they were slightly higher than what we saw with apremilast. And then general adverse events were pretty comparable amongst the groups, but adverse events with apremilast were a little bit higher here. Headache, diarrhea, nausea, no surprise, dramatically higher with apremilast compared to Sotyktu. Sotyktu's numbers were comparable or lower than what we see with placebo. And in terms of nasopharyngitis and upper respiratory tract infections, numbers are pretty comparable across the board. So
it makes sense, Ben. I mean, this was a drug that had been out, since 2013 or 14, and it had been used extensively as an oral agent for psoriasis. We all used it. It was well established, had been commonly used. And what they were looking to see is, does Sotyktu work better? And they had definitive, true head-to-head data to show that Sotyktu was significantly superior to apremilast. But did we run into some of the same problems or something else compared to apremilast? And this proved that Sotyktu did not. So they were out to show where they fit in versus the current agent that had been commonly used. So I think the design of it's very helpful information. Extremely helpful.
I think that's an excellent point. And I also think, I'm not here to throw shade on Otezla or apremilast, but my feeling with apremilast is when used as a first-line agent, and when patients don't respond, and what we see is, 2/3 of the patients do not achieve a PASI 75. I think it actually turns patients off and questions the next medication. They're like, well, if this was the first line medication, I had all this tolerability issue, you know, why would I want to go to another medication? And then you have to kind of explain away and talk yourself out, or, you know, explain to the patient why, you know, these other systemic oral medications or biologic medications don't have that adverse event. So I generally stay away from apremilast for the majority of patients because of the lack of predictability for response and the tolerability issues that we experience.
And the predictability of the intolerance. You know, a lot of people are going to get it, right?
Absolutely. And I have to say, it still fits a place in my treatment algorithm. I use it as an add-on, you know, newer generation DMARD in patients with psoriatic arthritis for apremilast with another biologic for the most part.
Right.
So like I said, there's a place for all of these medications. And this is that 5-year safety data. And I think the top line says it all, which is no increased adverse events, this is per patient years of exposure from year 1 to 5, except for COVID, but because that changed during the course of the studies. And it was more of a timing thing rather than medication induced issue.
Right. Yeah, it didn't have any study had more COVID going on in that study, not necessarily related to the medicine. But I think what's so interesting about it was when Sotyktu first became approved, and there was a discussion, it binds differently, it's allosteric, it doesn't have the crossover to create some of the issues that led to the box warnings and some of the things that we would test for, that you're not required in the label to get the blood tests that you are with the Janus kinase 1, 2, and 3. But some people were still suspicious. Well, you know, I'm going to wait and see, because they only had 1-year data. Then you had 2-year data that didn't show any difference. Okay, is that long enough? Well, I want to go a little bit longer. Well, we're now out 5 years. How much longer do we have to go before we show you that nothing's changed from the very beginning? You know, there's nothing, the FDA hasn't said, hey, look, we're going to put box warnings now, because as time went on, we're seeing some of those signals. We're not. So how long do you have to go before you're convinced that Sotyktu does not have those issues, right? No more than placebo or apremilast when they did the studies, right?
Yep. I agree with you completely. And I think that for me, this was early in the course because we really didn't see meaningful signals in terms of transaminitis at a high rate or, you know, lipid abnormalities, but we do have that longer term data that we'll get to in a sec. Excellent point. So let's just talk about some of the ISI important safety information. We know Sotyktu is indicated for moderate to severe plaque psoriasis adults who are candidates for systemic therapy. Hey, if you had a bad experience with the medication, or if you're on any other potent immunosuppressant, hey, don't use Sotyktu, okay? Hypersensitivity reaction, this is actually verbiage that's in every biologic and small molecule that we use in psoriasis, pretty much the same thing. It's kind of a catch-all. Infections, it can increase the risk of infections, okay, including serious infections. So if the patient just got out of the ICU, hey, don't be a dodo. If a patient, you know, has an active infection going on, don't start the medication. Consider holding it. My threshold is, if you have a fever over 101, give me a call. If you've got a cold, I don't care. I don't need the phone call. Do you do anything differently?
No, not really. Like, and if they develop herpes zoster, stop it. When the herpes zoster's over, you treat it. You can restart the medication. That's how I handle that.
And that's a good highlight. Just remember, any patient on any immunomodulator, that includes Dupixent or any biologics or Sotyktu, if they're 18 or older, they're eligible for the shingles vaccine. Okay, it's not a live vaccine. I strongly recommend it. I got my shingles vaccine. Yes, I turned 50. I'm sorry, I know, but I got it. It was not.
You could be my kid. I'd be so proud of Ben Lokshin with my son. Oh my God. Oh my God. Right.
We can drop the paperwork, but I do have a couple wants in that list.
Okay.
Okay. So, oops. Keep going over that. We already talked about viral reactivation in terms of herpes simplex and herpes zoster. TB, I will say, in the clinical trials, 4 patients with latent TB were treated with Sotyktu and received prophylaxis. None developed active TB. Remember, people get exposed to tuberculosis. Okay, you don't need to be on a biologic or a TYK2 inhibitor to get exposure to convert to a positive quant gold or PPD or T-spot. That just happens. Okay, the important thing is none of the patients developed active tuberculosis. So they do recommend ordering a quant gold at baseline. My personal benism is I have no problem giving patients samples, a limited number of samples. Like, I can't submit the prescription until you get your blood work done. So if you want to take, a few weeks of a medication, patients' heads aren't going to explode. But and those are for the patients that I trust. But that's the only test that is recommended getting a TB. Okay, malignancy, including lymphomas, were reported. It doesn't seem to be. It seems numerically it was actually higher in the group, but we do not see any label change regarding the box warnings regarding lymphomas. Okay, rhabdo and elevated CK. We saw the CPK was higher than what we saw in the placebo group, but it should be noted in long-term extension, we don't see any amplification of the signal, and there still is no recommendation for ordering CKs. We covered that. Laboratory abnormalities, we're actually going to highlight some of that in the upcoming slides in terms of triglycerides and transaminitis. Immunizations, don't give live vaccines, okay? And this is that JAK paragraph, because TYK2 is like the step cousin to the JAKs. And because this actually binds to the regulatory domain, which is different than any of the other of the JAKs, there's no spillover, and we'll see that in an upcoming slide, that really we don't see any of the hematologic adverse events attributed to JAKs. Moreover, we see none of the box warnings attributed to the JAKs. Pregnancy data, there's no pregnant or breastfeeding women were enrolled in the clinical trials, so it's recommended that pregnant and lactating women do not receive this medication. And if you have hepatic impairment, so TYK2 is not recommended with patients with severe.
It's severe.
Yeah. The key is severe there. So if they're yellow, okay, don't treat them. If they have mild transaminitis, fatty liver disease, which many of our psoriasis patients have, I don't care, no big deal. So I like to say, if the LFT, if AST and ALT are not 3 times the upper limit of normal, it is anywhere from upper limit of normal to 3 times is a slow blinking yellow light for me, which is, hey, proceed with caution, maybe follow them a little bit closer. But remember, LFTs are not mandated as baseline labs or labs throughout the course unless clinically appropriate in those patients. I do think that all patients with psoriasis should have a primary care doctor, and they should be getting labs with them as well. What kind of adverse events keep me up at night? Well, I mean, a lot of them do, and it's more significant ones. But certainly these adverse events that were of special interest, including non-melanoma skin cancer, malignancies, serious infections, herpes zoster, venous and arterial thromboses, and MACE events, were the things that cause a lot of anxiety with the JAK TYK2 class. But once again, TYK2 is a different animal. So let's just dig into this data a little bit, and it's so nice to have a Premolast on here as the active comparator out to week 52. Okay, so these thin bars are the confidence intervals. Okay, so how confident you are from the data, and anything within those confidence intervals, if they overlap, there's no statistical difference between them. So what do we see in terms of non-melanoma skin cancer? No difference statistically. Malignancies, no difference statistically. Slightly lower, so TYK2 in contrast to non-melanoma, slightly higher. Serious infections, and most people can attest to the fact that a Premolast is very clean in terms of the rare and scaries. Okay, serious infections, numerically the same statistically. I mean, in confidence interval is actually a lot greater with the apremilast. Herpes zoster, we do see a slightly higher rate. Arterial thromboses, venous thromboses, all extremely low. No statistical significance between those, and same with MACE events. Numerically, the lowest was Sotyktu, but no statistical difference between the three groups.
And you're looking at these numbers that you see on the left. They're all one or less. If you had 100 patients per year, how many would get that event? And they're really falling the same between placebo, Sotyktu, and apremilast with very little difference. So when the FDA was looking at this data, this is the data they had before they decided on the box warnings. What would be the justification for giving those box warnings? Sotyktu wasn't doing any of them. And so if they would have given the box warnings for Sotyktu, they would have had to go back and put them on apremilast because the data was the same. I mean, when you look at it that way.
I think that's really good commentary there, and a great point. Yeah, the rates in terms of event per 100 patient years are extremely low across the board here. And as I mentioned earlier, no new.
Ben, I'm gonna lead you in. Ben, can you tell us what happened at 5 years?
Well, there's actually no new safety signals, which is nice. So we don't need to go line by line, but what we see is no new safety signals and no amplification of safety signals, and just highlighting that includes MACE, venous thromboses, malignancies, non-melanoma skin cancers, and on, including lymphomas, which the rates, were extremely low over time. Anything you want to add to this, Jim?
No, I just think you're looking at numbers here, other than the serious infections, which are very low. Everything was below 1. With the exception of COVID and a few others that popped up, like folliculitis, 1.3. So that's 100 patients treated per year, and you're still seeing very, very low numbers. And these were very similar to what was on in the placebo group when we had a placebo group. So you're out 5 years, and you haven't been snake bit by any of these things.
Yeah, and this slide, more than any of the other safety slides, really solidifies and creates a tremendous amount of confidence of what I articulated to the patient.
Yep.
And if you weren't comfortable at 1 year and you weren't comfortable at 2 years, certainly 5 years, everyone should have buy-in. Now, looking at some adverse, we talked about transaminitis, and what we see, so the red lines here are the upper limit and lower limit of normal of AST and ALT, and this actually goes out through 4 years, including the pooled poetic psoriasis 1 and 2 and long-term extension. And what do we see? Straight lines right smack dab in the middle in terms of transaminitis. We do see, a few patients, okay, in the 16-week placebo-controlled study, there are 9 patients, which is 3.6 events per 100 patient years, that were high, with Sotyktu compared to only 2 patients with placebo. Okay, and we see comparable numbers with AST, but really, I think it was more of a numerical difference than when you see a larger patient population over a long period of time in terms of a drug-related cause. So for this reason, I don't check LFTs, I don't check labs. I do recommend they have a primary care physician. Anything you want to add to this side, Jim?
No, pretty much. And really the bottom line is, if there's an individual patient, you're the clinician. The package insert is not, the FDA is not. They're just giving you some background information, important information. But if you have a feeling that you want to check something, do it. There's nothing, you're going to be getting a quantiferon gold. So if you want to check it for whatever reason, because there's other things in the history, there's nothing stopping you. But the package insert is not telling you you should have done it, and then you didn't do it. So,
yeah,
but you can still decide on an individual case-by-case basis if you want to get a certain test. If somebody's pumping iron all the time and you say, hey, maybe I should check a CK, then do it. That wouldn't be me. I don't know about you, but the pumping iron, but you're the clinician. You can decide on any given patient if you want to check something. But this is what the FDA, the guidance the FDA has given, which Ben is making very clear for you.
Very good point. And then this is focusing on triglycerides. If you check my triglycerides at any point in time, they're probably somewhere between 150 and 200. I tend to run high. But what we see is, patients with psoriasis probably run a little bit high too. And we see that they're right hovering at the upper limit of normal, but don't change. There's no trend that they continue to rise or make any difference, and in terms of the cholesterol, there's no effect, and this is in stark contrast to what we see with the JAKs.
So what's interesting, if you were at 150, the mean would be maybe you went up to 160. The mean was about 10 difference in milligrams per deciliter. So you're talking really about very small increments.
Not moving the needle, and I don't think that triglycerides plays a huge role in terms of my lipid management if it's 150 or even 175, but I do recommend, once again, patients have a primary care physician. Yeah. So how does the safety profile for Sotyktu compare to what you thought? Well, hopefully you have after this talk, you have a lot of reassurance of the fact that there's no new safety signals, there's no amplification of the safety signals, that the rare and scary things that we talked about are really things that shouldn't concern you as a physician, and you should articulate that to your patients. So how does Sotyktu work? Well, remember, it works inside the cell, and I think this is a really good schematic, and we'll use the IL-23 binding the IL-23 receptor as a good illustration. This is showing kind of the Th17 production, but what we see is that TYK2 heterodimerizes with JAK2 in the intracellular domain of the receptor, causing dimerization, phosphorylation, recruitment of STAT. STAT gets phosphorylated, it dissociates into the nucleus, and that results in gene transcription. And in this case, with the IL-23 and IL-23 receptor pairing, we have gene transcription producing IL-17, okay? Because this binds to the regulatory domain, which is unique to TYK2 and is different than what we see with the JAKs, that once again, there's really no spillover into blocking JAK activity. Now, binding to the active domain is a different story, and there are other TYK2 inhibitors that are on the horizon that do bind to that active domain that might have different side effect profiles. So this is actually unique to Sotyktu, and I think it's really important to highlight that difference.
Extremely important, the major difference. Right.
And this is actually highlighted here in terms of the TYK2 blockade, really highlighting that it just focuses on the immune system and immune response, IL-23, 12, interferon gamma, and it doesn't have any effect in terms of blood cell development, metabolic activity, and lipid metabolism that we see with the various JAK subtypes. So how do you start Sotyktu? Well, remember, the only lab test you need to do is a quantiferin gold, but as Jim had mentioned, if you feel that it's in the patient's best interest to check other labs, obviously do it. You treat the patient, okay? But you're checking those labs for the patient, not for the medication. Right. It's once daily dose in 6 milligrams, okay? So what other factors are important when considering Sotyktu for your patients when topicals aren't enough? Does this mean that we're getting to the end? Yes, it does. And taking it full circle is, I think this is an excellent consideration for those individuals with moderate disease, where you're looking to pivot from a topical medication, for those patients that have tough to treat areas like the palms and soles and scalp. And remember, scalp involvement, we see that 70% of those patients achieve a scalp specific IgA of 0 or 1, okay, on this medication, about twice the rate that we see with the Premolast. And remember that the Palmer plantar PGA we see at 16 weeks was 56%, and as Jim mentioned earlier, rises over 60%, as you continue on the medication. So thinking about any of the patients that are looking to get into a systemic that you think would benefit from a systemic agent, I always like to think that this is a great option for those individuals that are young, that are in college, out of college, because keeping an injectable medication in your fridge is a little bit of a nuisance. Getting that shipped to your dorm or a group house is also something that, some individuals just don't want to share medications that they're on, or have people know this is a little bit more discreet, a pill bottle you keep in your room, you take once a day, no big deal. Okay, so evaluate for.
You don't have to worry about with food or without food, other drugs that they might be taking that might interact, lipid lowering agents, blood thinners, antihypertensive. There's no drug interactions noted. That's a big issue in some patients.
Yeah, I mean, I think that's huge. And it's huge for us as providers because we don't have to worry about those drug interactions.
Right.
Or and patients don't have to fit it into their lifestyle in terms of, oh, do I take it 3 hours after this or before this or with food or without food? No dose titration. This is especially important for my young men who can't figure out how to do dosing or remember when to take medications, especially for the ones that are dosed every, 8 weeks or 12 weeks or 4 weeks. And it's got a short half-life, but long enough to be dosed once a day. Is a 10-hour half-life. And as of January 2025, so TIC2 is covered for 8 out of 10 commercially insured patients. This is a dramatic departure from what we had early on in the course. No branded step requirements for these patients. And I'm not expecting you to remember all these specialty insurance companies and specialty pharmacies we deal with and PBMs and blah, blah, blah. But the assurance is if you prescribe it, there's a very good chance about 4 out of 5 patients are going to get covered. If they don't, the bridge program is robust. They're going to get free drug for 2 years at least. So really, how do we get our patients on this medication? Well, definitely make sure that you enroll them in the copay assistance program so they can pay as little as $0 per month, which is very important to do. All these medications are expensive, so doing everything we can to decrease drug costs for our commercial insurance is important. So when topicals aren't enough, your reflex should be start so TIC2. It's got greater efficacy at 16 and 24 weeks, especially in terms of PASI 75 and PASI 90 compared to apremilast, about twice the efficacy in PASI 90 at 24 weeks and 16 weeks, simple once daily dosing. That 5-year of efficacy and safety data means a lot to me. And I think that articulating that to our patients also provides them the assurance that they're not going on a new medication that hasn't been tested. Okay, that a lot of those unresolved questions that some of our more cautious patients have or providers may have, I think have all been addressed at this point. Anything you want to add to this, Jim?
No, I just noticed that we're running a couple of minutes over. I'm looking at the questions that were being asked, and you just addressed those about the long-term efficacy data, if there's anything additional. And you mentioned about the access, and the patients would be moderate or severe plaque psoriasis where topicals weren't enough. This would be a consideration. Is there any, or the special sites, correct? The special locations, right?
Yep. For special locations, it's face, scalp, genitals, palms, soles.
Yeah. And all of those, there's data on that. If you have issues with the access that you don't know, with your office staff, contact your representative and have them help you, because rarely is there a situation where you're not going to be able to get access to the medication. So Ben, thank you very much. We do have another program that's going to be coming up. I see Roxanne on the line, who's been a big help tonight, watching over us. I didn't get any texts. You guys are screwing up, So I guess we did okay, Ben. So
they were all silenced. I was just looking at my phone. There's a lot of them.
I think mine just didn't come through. September 9th, we have the inimitable Latanya Benjamin's going to be talking about atopic dermatitis, the strength they need with the safety they deserve for atopic dermatitis. So that's tomorrow evening. So we have back-to-back IDEF. Ben, it's always great to see you. Roxanne, are there any final comments from you?
No, thank you so much. And thank you so much, everybody, for joining us this evening.
Thanks, Jim.
Bye.
Thanks, Roxanne. Have a great evening.
Bye.
Take care. Bye-bye.